Good morning all. Welcome to the seed session for today. I'm going to be critically appraising a health economic study. So this is actually a sequel to the previous week's study which Dr. Thomas did. He did a systematic network analysis of diabetic drugs which is done for the American College of Physicians. We'll go into a small scenario. So imaginary scenario, the Tamil Nadu government is conducting a health budget meeting and they want to analyze the costs and plans for the future. The main focus is on medications for non-communicable diseases, which is given free in government hospitals. There is a discussion on newer anti-diabetic medications. Is it going to be better? Is it cost effective? Can we replace or add on to the existing treatment? So we are present, we are called as a part of the expert medical team and they wanted to guide the discussion. So what is the evidence behind the newer medications is cost effectiveness. So for this question, I have gone into literature and found this article which is published in Annals of Internal Medicine in April 2024. So this is the cost effectiveness of newer pharmacological treatments in adults with type 2 diabetes, a systematic review of the cost effectiveness studies which were done in US for the American College of Physicians. With this, they were planning to do a guideline based on which they can apply these results so that it is cost effective and they are able to help the type 2 diabetic population. So going into this systematic review, I would like to start off with the CAST questionnaire for systematic review analysis. The first section is are the results of the review valid. First question is that the review addresses a clearly focused question. For this we have gone into the PICOT statement. So P is they have included all type 2 diabetes mellitus patients. The intervention was newer anti-diabetic medications. So they have included everything which is new except for metformin and sulfonylurea and normal regular insulin. And the control was background therapy. They also compared it within the newer OADs also and the newer insulin, as in long-acting insulins. The outcome which they have looked for as for the review is author-reported cost per quality. The author means the paper-reported cost per quality which they have given. So what does quality mean, which is already dealt with, but I'll just repeat once more. This generic measure of the disease burden, which includes both quality and quantity. You've seen this diagram also. I'll just add a little bit. So, in simpler terms, it helps you like this is the quantity of life. This is going to be the quantity of life, and this is going to be the quality of life. If you take it in simpler terms, clinical terms, it means morbidity and mortality. So this could be mentioning about the mortality, how early is the mortality going to happen, and this is going to be the morbidity, with how much morbidity are you going to live. I think it was self-explained and sir also explained clearly that you keep adding on the quality depending upon the quality of life you have. It goes from 0 to 1 per year we calculated and keep adding. Say for 3 years, 1.8 and 0.6, you add it up, it comes to 2.4. That is the quality you will gain with an intervention. So this is the quality which you have gained with the intervention, and this is the quantity which you have gained of meds. That is what this means. So this is very important for this to understand the rest of the slides. Time period, there is no time period. They have just gone through, they have not looked at follow-ups. They just looked at cost-effective analysis studies. There is no time period in this. The study design which they look for is cost-effective analysis studies, so which we have already mentioned. The RCTs are done, effects are looked up, and both are being compared to find out if it is effective or not. Those are the studies which they have looked for. So did the authors look for the right type of papers? As I said, cost-effective analysis studies which report ICER. So what is ICER? ICER means incremental cost effectiveness ratio. Say an intervention A is there and B is there. How much is B going to be and how much is B going to be effective and how much extra cost it is going to give that you need to get that effectiveness. That is what ICER in simpler term means. How do you calculate it? ICER is equal to cost of A, intervention A minus cost of B, divided by effectiveness of B minus effectiveness of B. That gives you a ratio as to how much extra you need to pay to gain one quality. So it is measured as dollars or cost per quality gain compared to the previous intervention. It could be nothing or it could be some drug already in practice. So that they look for the right type of papers in this.
Then they will take DAPA as a cost and effectiveness.
Yes, exactly.
But if there is no head-to-head comparison, they will not be able to compare directly.
Yeah, they need to base it on RCTs. Without an RCT, you can't be able to directly do it. You need to have baseline RCTs which you can include. So a cost effectiveness study is that. So you do a cost analysis between the drugs, you do an effective analysis, and then you combine all four together to get one cost effectiveness. That is what is gained out of each. So that is how you can calculate APPRAISER. You need to do the cost analysis of the drug, the effect analysis of the drug, which is the usual RCT which we do, and then you combine both. So randomized control trials which we usually see are effect analysis. So we don't usually see cost analysis. Cost analysis is just doing like we say like two drugs you can take, say metformin and SGLT2, and then compare each cost and see how much extra cost you need to treat that. That is it. So when you combine everything, it's nicer.
Yeah, just to add on. So for effect, definitely RCT is the best study design to look at the effect. So how do we look at costs is, some of the studies they would have included cost analysis also as part of their study design, and they will keep calculating the cost as and when it happens. And then finally you get two costs. Cost by treating with SGLT2, cost by treating with GTP4, you will get in both arms. And then you know what is the difference in cost in both arms, and then you know what is the difference in effect in both arms. That's one way. One way is indirectly imputing the cost. You do an RCT, you find that it is effective, but later on you would think that okay, it is effective, but will it be cost effective? Then what people do is, they will just impute cost. They will assume that okay, this patient had a hospital stay of 10 days, so 10-day bed cost would have been this. This patient received dapagliflozin for so many days, so the cost of the medication would have been this. So they just assume cost. It will not be a directly calculated cost, but for each and every step, whatever has happened during the RCT, they will assume that this would have been the cost based on the usual cost, usual bed charges, usual medication charges. They will just put that in there and then see if the cost differs between the two arms and whether the cost is higher or lower.
The cost of it is not the cost of the drug, it's the cost of the...
In everything, including follow-up, investigations, admissions if any in between, complications, adverse effects, everything will have to be costed. It's not just the effect alone. Even adverse effects will come at a cost. So all those costs also will have to be included.
An ideal study should include all costs, and that is called a complete analysis. If it's not done, it's incomplete. Then you can't actually take it in. Okay, so they have reported, they have looked for studies which reported ICER. So do you think all the important relevant studies were included? So this was, as I said earlier, this was done in US for ACP, which is American College of Physicians, to form a guideline. So they had a clear idea before starting out. So they had taken only studies which had a US perspective, done in US, non-industry funding sources, because if it's pharmaceutical based study, they might show that it's actually beneficial and cost effective, so that will not be useful. And they have searched databases like Ovid, Medline and Embrace. They looked for articles which were published between 2010 to 2023, fairly recent, and limited the search to English studies only. So if we didn't know the background of why they're doing it, we might answer it as no. But as they wanted to form a guideline, in their perspective, this seems like the right kind of papers. They could have additionally checked global cost effectiveness analysis registry, which could have given them more studies, is what I felt. So they have done an immense and detailed search strategy to find out studies which will be able to pick up and analyze during this cost. I will not go into detail. So now how much records? They identified almost 3,900 records in Medline, Embrace and economic reviews. They had some duplicates because they've been searching which could be published, which could be seen in both the databases. The duplicates have been known, which is 192. 3,708 records were triaged, and they've excluded based on their criteria, which is like US based, should not be pharmaceutical bound, it should be drugs like it should be prospectively done and not retrospective. All those like some exclusion criteria they have, with which they have excluded 3,285, with which they got 423, and when looking into the text in detail, they still found certain studies not fulfilling the inclusion criteria for the study. So they have excluded that and come to 9. They actually have reviewed only 8. I'll come to that later. So did the authors do enough to assess the quality of the included studies? So the authors used Drummond criteria. Drummond criteria is not actually a very hardcore criteria for CEA, but this is the most available criteria which they have been using, and they have used to assess the study of this. How did they do it? There is a single reviewer who used the Drummond checklist to check each of the study, and they had a group discussion to sort out any differences. So they had finally given us low, some concerns, or high risk of bias. Coming to that table, Here you can see they found that one study had high risk of bias and rest all had some concern. Only two studies were actually really done well, which showed low concerns. So other problem, they did not actually review this study Zupa because there was something called as time horizon which will come to later, which they assumed for only the next 3 years and did not do a lifetime horizon. So lifetime horizon is something like if you give diabetic drug to someone, they can have those effects toward like till end of life. So in this study they saw only till the third year of their life, like third year since starting the drug. So which was not right is what they felt, and that could cause the effectiveness to go down, what they felt, and so they have rightly excluded the study in the analysis. So this is a detailed checklist which they have used to appraise each of the cost effective analysis studies, and there were a lot of concerns. Very few studies were actually done really well. Only 2 studies were actually done. There were a lot of concerns. So you can see here again concerns, and only 2 were low. So this is a systematic review, but they were not able to analyze it together as a meta-analysis. Why? Because the population was similar, but drugs were different. The follow-up was different. The amount of cost which they incurred for each, which will come to later, like each drug, each cost of adverse effect, the treatment charge, everything was different. So they could not do it as a meta-analysis. So they rightly not combined the results. They just done a systematic review and reported the results. So from now on, I'll go into the class question for economic analysis. So coming to that, effects of intervention identified, measured, and valued appropriately. So if it's a cost-effective or cost-utility analysis, what you need is cost per quality gain. You already told about it. So that is what will help the guideline maker or the government to choose whether this drug is appropriate for the benefit of the citizens. So they have rightly chosen cost per quality gain as the effect which they wanted to look at. Again, I've just put up APPRAISER again just to read through. So going in, I'm just showing that each of the study had shown author reported cost per quality gain as the outcome. So where all important and relevant resources required and health outcome cost for each alternative identified, measured in appropriate units and valued creatively. What does that mean? As I said initially, this is about all costs. A patient coming to you doesn't have just the drug cost. They can have effects due to that. So say diabetic population can have what kind of complication? What do you think they can have? Okay, like very common with the diabetic medication related to that. So hypoglycemia is the most common one which they look for here. Some studies did not look for it. I'll come to that. So here you can see they have done something called as wholesale acquisition price. How much did they take for the acquisition of the drug? And they also, some studies have given individual prices of the drug also at what they had calculated it. So this study also gave it like that. But there were a few studies they could not give entire details about it, which is not right is what is that. So if you go into the next thing, that is outcome event cost. They have mentioned one study just looked at expluency level. They did not look at adverse event, they did not impute cost for that. While some other studies have done from the Medicare national payment, from the insurance database, they have taken as to how much they have spent for each admission. Say hypoglycemia, how much was it? How much do they think it's gonna cost? That is what they've imputed and analyzing this. So there are few missing data regarding the costs. So where costs and consequences adjusted for different times which they occur. So this is what is called discounting. So I also talked about it. I'll tell a little bit. This is a mathematical way to adjust for the cost which is going to happen in the future and the benefit. So there is always a disagreement whether the benefits also have to be discounted or not. So in this study, what they did is they discounted only the cost of the drug or anything around the health and the adverse events which they have gotten admitted with. They have not looked at the effects. They have not discounted the effects. So what is discounting is, say today the cost of one drug is going to be 100 rupees. Let's say in 5 years the drug's cost might be higher. So doesn't mean that you cannot give the drug today and give it after like 5 years. So to adjust for that and say that cost has to be included in the current analysis to present value so that you can give it as a bundle. So how will you adjust that cost which is going to be higher in the future, higher or lower? We don't know. Okay, higher or lower in the future, which could include the drugs, the events, and everything, and discounted such that it is accounted into the present value, which included the present value. That's the mathematical way to adjust everything. They give it as percentages. Each country has a percentage as to which they can discount. Say, US has 3%, some other country has 5%. So they'll be like, this is the rate at which we will discount. So that the whole cost is included in the present value, even the future cost. So the benefits also happen in the future. The cost might happen in the future, but how will you include it into the present value? The mathematical way to do it is by doing discounting. This is an economic principle which is applied in health also. Understood?
Just today, the cost of an inpatient admission for the KSA is how much do you think it will be? 50,000. 5 years from now on, what is it likely to be? 80, 90. So, as years go on, you think that there is some inflation going on. At what point of time would you want to look at benefits? That you have to decide. Whether you want to calculate the benefit as of today, or you want to look at the benefit as of 3 years later, or you want to look at the benefit to the exchequer at 10 years later. Suppose you want to look at the benefit as of today, then you will have to keep discounting it or coming down on the value. So as of today, the benefit monetarily by numerically wise, it might be lesser. But if you are going to look at it later on, then it may be greater or lesser depending on whether benefits are more or adverse effects are more. Literally, it is something to adjust for inflation that is going on, and depending on when you are looking at the benefits, you may have to either inflate it or deflate it depending on when the adverse event or a benefit is going to happen.
So have they done discounting? They have mentioned in all the studies they have done discounting is 3%. US based studies have a 3% discount rate. One study did not state it though, and they have not given justification as to why. I think more likely to be that it's the rule of US to have a 3% discount rate. So what are the results of this evaluation? So I think we have already seen this. This is called the cost effectiveness plane. So finally, at the end of a cost effective analysis, you need to plot on this and find out is it going to be useful or not, and if it's going to be useful, then like how do you apply it? That is what finally means. So here we have cost on the y-axis and then effectiveness on the x-axis. It is switched from what Sir said. So here you see that anything here is effective as per treatment, and anything up is going to be costly. Okay, so this is going to be less cost. So what we want from the cost effective analysis, what is the good outcome for us is something which comes here, which is less more effective, less cost than the intervention which is already there, or it would be nothing also, no intervention also. So if it is there, then this is what we look for, and we immediately say that this is cost effective and the effectiveness is good, there is low cost, and we directly can go into applying it because it's lesser cost than the intervention which you are already doing. While this is something where we don't want to go to. So lesser, like higher cost, but lesser effect. The effect that could be detrimental also, we don't know. So this is called the old treatment. Say A is the new one you're looking for and B is the old one. So the B one, which is the older intervention, actually dominates the A. So that is called dominance. That's what dominates mean in this graph. So when you come here, or dominated, if you can say like A was dominated by B. Or you can say here it will be like A actually dominates B. Understood? So here A is not good, less cost, less effect than B. So B dominated A. While here A is better, low cost and more effect. A dominates B. So you might find this word dominate in cost effective treatment. So whenever a problem comes when you have people here or here, as already said, and this is the threshold. What is your threshold? Actually, there is a threshold of 5 lakhs. So he can have, like, if it's less than 5 lakhs, he's ready to pay. So that depends on the government institution, the person who's reading this paper, who wants to apply resistance to themselves. That is what this threshold is. Threshold is, an author can do a threshold, but if you're not agreeable, I'll come to that later. We have a curve for that. So if someone is here, again, lesser cost, but a little bit less effect, but still might be okay for some people because the cost is lesser. The overall cost becomes lesser. Here the cost is a little bit higher, but the effect is definitely better. You may still want it. Someone might be like, it's very costly but very effective. Some people might want it. So depends on personal preference of the person who's looking at the study itself. So what were the results of the evaluation? Going in. So as we look at DPPS, so we find ourselves like in our OPDs, When someone is on metformin and sulfonylurea, the next thing we look for is DPPI-4. Steroid gluten is what we generally go for. So is it effective or not? So looking at here, they have compared it with, like, added to metformin, they have compared DPPI with sulfonylurea. They just mentioned that it is more expensive and less effective. So they said that it was more expensive and less effective. So if you take it as a cost effectiveness plane, what there does it come to? So this is cost, this is effect. So more expensive, which is here, which is on this, and less effective. So the effect is less. So it comes in the place where we don't want it to be. So will you be going for it? No. So rightly they have said that it's more expensive, less effective. You are not calculating ISO. You don't have to calculate. Unless it falls in this or this, you don't have to calculate ISO for that. Then comes, like, they've also compared it with other, like as a DPPI versus engaged insulin on an already patient with metformin and sulfonylurea. Is it like an add-on drug? Is it good as an add-on drug? Still was more expensive and less effective. So while they look at, so I'll not come to this, but with this we can say like DPP4, will you be able to give for the patient as a cost effective? You can give it, you can choose to give it as yourself, but is it cost effective? No. So this is from the study itself which I picked. Again, you can see here metformin plus sulfonylurea plus DPP versus engaged. They have done something here which means less effective, more expensive. They have not calculated anything for that. So now I'm like thinking like as to what else can I do. So I want to give a decision to them. So I'm looking at good evidence papers. I found that Cho et al. In 2022 has good grade comments also, and the certainty of evidence was good according to the reviewers. So with that, I'm going into their study in detail so that I can find both SGLT2 inhibitors and GLP1 done in this study, which goes to good. They have good evidence. What evidence do they give? So I've gone into that result alone, which shows that SGLT2 is comparing with metformin as a first line drug. They checked as a first line drug, and they have identified that it costs 508 or 5 lakhs dollars per quali. While they have also tried it as an add-on drug. So they have added this as an oral GLP1, SGLT2 on already patient with metformin. So that also shows that there is an additional cost, but effect is also better than that. But you can see that the quali is 5 lakhs or $500,000 per quali there, and $1 million US dollars per quali here. So now you know where does it go. Like if you put the cost effectiveness plane again, effect, cost. So it's better, but it's way costly. So where do you put it? So I would say A, B, C, D. Where do you want to put it in? So as for the study, they have looked at the RCT and decided that it's better, and they calculated the ISR for that. So once you calculate ISR, means it's better and it's effective and the cost is more. That is when you less, or the cost is less, either way. So that is why they calculate the ISR. The ISR is showing that the incremental cost required to get an additional effect is 5 million per quali, one quali. So one quali, he said 5 lakhs to spend. So here they have 5 lakh USD. So whether you will be able to do it or not, or do you want it or not, is the next question you have. But where does it come here? It comes in B. So you plot it here somewhere. It's too costly, it's too. But does it come under the threshold or not? Is the next question you have. So that is the decision you need to make. So we know that it's effective. We know that it's very costly. And do we have to go ahead and apply it or not? That's the next question. So this study is good, and they have come with that idea. So we have two drugs, SGLT2 and oral GLP-1. While you can see injectable again was dominated by the SGLT2 and metformin. So we are not going to look into that. Okay, coming to that. Next. So I've looked at other things. The evidence is not that great. So I'm not going to go into the rest also. The evidence. This is the individual studies which are reported. I'm again not going to go in detail. They have appropriately checked between the drugs, the quali, and the calculated ISO for each. So there are few other drugs which are good, but the grade of evidence for that is very less. So this is the final result the study is given. So what did they also come up with is that GLP-1 and SGLT2 are low value. So what did they mean by low value was That is according to the ACP, American College of Physicians guidelines. The low value is anything more than 150,000 per dollar per body they identify as a low value drug. Why high value is anything below the level of less than 50,000 dollars they want to spend. That is the threshold they have set. They have a set threshold which every country would have. Might change depending upon which disease they are going to treat also. So based on that, they have mentioned that both are of low value, which is more than 150,000, and now they're going to give it back to the ACP saying that you find whether we want to go ahead with this or not. So you also found that the GLP-1 SGLT of intermediate value means it's between 50 to 100, and insulin was expensive. Few things were not certain, and two drugs were not useful. That is DPPI and injectable were not great. So that is the result, and they have appropriately calculated everything and looked at it and come to a right conclusion. So was an incremental analysis that I said it was an ISO was calculated. So sensitivity analysis. So what is sensitivity analysis? I think just a little bit. So sensitivity means there will be multiple variables in a population of that study. So some might be diabetic, some might be CKD, some might be getting a drug which is, like say, it was not a long acting drug or short acting drug, by the way. And what they do is they include analysis. They change the variable, one variable, they try to change it and see if the results are consistent or not. They may increase the diabetes, they may increase the CKD or bring down, or the cost they may go up or down, and see if the results are still consistent or not. That's what sensitivity analysis means. They have done it in few studies, but not in all studies. So I'm not very sure whether the sensitivity analysis was adequately done in the review studies.
Yeah, just to put it in. I mean, you do effectiveness, you say effectiveness, and is it going to give you the same amount of odds ratio every time that you do a study? No, it will vary. That's why you have 95% confidence interval. So you put the effectiveness in the lower range, and you put the effectiveness in the higher range. See what is the ISER that you are going to get. Similarly, adverse effect. It may not be the same always. You just decrease the adverse effects, increase the adverse effects, see whether you are going to get a similar benefit. So similarly, suppose if they have assumed hypoglycemia to be 5%, but you think in your setting hypoglycemia may be much higher, then just vary the value back and forth to see whether you are consistently getting the result in the quadrant that you are looking for. If always within the accepted threshold, then you will go ahead and accept. If it goes beyond the threshold, then you will say that when I am varying the probabilities, when I am varying the individual probabilities, I probably feel that it's going beyond the threshold, so I may not use it. This is not only in the effect, also in cost. Suppose you don't agree with the cost of the drug which is there. You impute your cost and see whether you are getting similar result within your threshold. If you get it, then you say it's cost effective in my situation. So when you say sensitivity analysis, it is within the effectiveness, adverse effect, cost, everything you may move back and forth. Suppose you say admission, you may not agree with the admission cost of them, so it may vary back and forth. You put both values and see. So that is what is sensitivity analysis.
You can just give an example here. They mentioned here that here in this study they have done one secondary analysis. Just mentioning that the drug, they have changed the drug cost from the average wholesale price to what the insurance company is going to reimburse. That makes sense. So they make sensible analysis to see if it's still consistent or not. Here you might see that they wanted to change the drug cost of tisabit as low as possible to try to come into the threshold. So these are sensitivity analysis which they try. Every study usually tries to say that is it going to be if the cost of the drug goes down, will it become sensitive? Will it become effective? That is the sensitivity analysis which they have done in few studies but not in all studies.
So yeah, finally you can conclude saying that as long as the medicine's cost remains less than 100 rupees, it is cost effective. But if it goes beyond 100 rupees, then it's not going to be a cost effective. Yes, because it will go to the cross the limit of the threshold. Similarly, you will say as long as the hypoglycemia episodes are less than this, it will be cost effective. But if the incidence of hypoglycemia goes beyond this, then it may not be cost effective. So that is how you will conclude based on the sensitivity analysis.
Coming to the last set, so these are research help in purchasing for local people. Is the program likely to be equally effective? So I find it's got this population is similar. They're just taking a broad population of type 2 diabetics. Whether the insulin is similar, the drug pharmacology is going to be similar. So population is similar, the effectiveness is the same. So but where it becomes different is probably the cost, and the cost will be translatable to your setting. I can't tell based on this because they have mentioned everything in USD and our costs, like our hospital price, our nursing price, doctor price, everything is different. So what can we do? So the overall need for intervention, the rate of events, everything is going to be similar. The individual cost will vary, but you can try to adjust for it. So what can we do? Probably a cost-effective analysis or sensitivity analysis based on local cost, and then find out like based on the medication events, everything you have to and see if it's possible or not. So is it worth doing in your setting the same similar study? So you don't have to do the same study again. You can always use this research. It's effective. It's costly, but the threshold you can come to a final decision whether the threshold is good enough based on your sensitivity analysis. So I'll suggest to the government probably if I am there that SGLT2 inhibitors and GLP1 analogs are the ones which you can look for, but find out what they can do. So my answer, I'll come to this again. So my answer will be that I'll provide the evidence for the SGLT2 and GLP1 analogs, but I'll tell them to do a modeling based on what they can. So the government has to now sit with the pharmaceutical company, bargain the price, find out how much lower price they can get, and then do the analysis and see if it's going to be cost effective or not. So that depends much on the economists in the government rather than us. So we can say it's cost effective, but how much cost it's based on them. So other thing is like we wanted to talk about that threshold. So the threshold usually, how do they come to that threshold is each country has its own threshold. This is a study from Lancet. This is published in 2023. That's what I'll put it here. So this shows USA has a threshold of say 1 lakh US dollars. So that is where ACP also came with 50, 100 and 150, and but differs with each studies. While here they have done an analysis and found that India's threshold should probably be $487, which would translate to probably how much, like 90. How much would it be?
60 to 70.
Yes.
500 into 70.
500 into 70, 80, probably 40,000, 50,000 rupees. So that is what the Indian government. So how did they calculate this? They wanted to look at how many years is your life expectancy. They calculated around 67. And they wanted to look at how much cost you're going to have, how much disease you're likely to have. Based on that, they come to that to see that this could be the probably ideal threshold. But the government decides what the threshold is. So this is the threshold which every country or institution or whatever has to calculate the threshold for themselves and say, okay, this is the threshold where I'm going to stick to. So India is going to say like $50,000 per quality is the threshold you're going to have. If they do analysis with the SGLT2, they do analysis with the rest of it and find that it's less than 50, they can choose to do it. They can choose to add it to the current program and say, okay, so we're going to do it. Because essentially they're going to disinvest from somewhere and put it in here, and they're going to lose money. Like they should have the greatest benefit here. So they're losing benefit somewhere and gaining benefit, and the benefit is more than what they can get in the other place, then they're going to go for it. So if it's above this, they might choose not to. So this is few threshold values which they given. US obviously has 50,000 here, what they've chosen. So say that this is additional to what the study says is the ending point of cost effective analysis. So say that you have seen this, you're saying 50,000. Say like Shakti doesn't want to do, no, 50,000 is too much for me. But I do not agree to the author. This agreeability I'm not going to say. So I want to do it myself. So they can do something called a cost effectiveness acceptability curve. So this gives you a curve as in like at what cost, how much effect is there as a graph so that you can choose. If you're going to say like I'm going to spend only 25,000, the best bet would be such an MBS. You can choose amongst you. You will like I'm not going to spend anything. Like, I want to go to the Thomas school and get 50 metformin still. You're like I am ready to spend other things like 75,000, and you want to add on drugs. Once this is exhausted, then the next thing you have to go is get leaflets according to this. But this might vary depending on the studies. You can see here it's combination again. At 50,000, you might be like this is the best thing to do. And at like 75,000 again, it could be with the insulin. So this is how you can agree yourself to this cost effective analysis based on your preferences. Maybe the individual institution or the government. So this is called the cost effectiveness horizon, which you can choose to agree to or not. So I think based on this, will I be able to tell them? I'll tell them to do their own analysis based on the cost they can do. But the regards which are effective, I will tell you this is effective.
With all these things, quality discuss the personal only who's to having, if you are diabetic,
They have to sit together and find what a quality could be. They have to define the quality, define the exert, everything has to be defined, and then they have to do the analysis and see.
oh, they're not asking patients.
There is
Patients,
part of
yeah, it's government will have to decide how much is government willing to spend to give one citizen a quality. So that if they have decided as 50,000, then if the net benefit is up to 50, if the net investment has to be less than 50,000 to give them a quality, then they will implement, they will procure and give it free of cost in all government hospitals.
the quality is from RCDs, like you would find from actual study where how much better quality they have and how much number they have. Different studies. You don't ask the patient like how much do you think is your quality. It's all based on statistics.
Alternatively, they can just see how many DTS they are having because of undergoing diabetes and say, okay,
Yeah, so what they need to do is the study is available, or you can create your own decision analysis, and they already have calculated all the costs. You have to see whether they have accounted for all the costs in your scenario, whether they would have looked at cost, direct bed charges, medication charges, everything they would have listed in the study. They have listed in the study. You have to look it from your perspective, whether the proportion is similar. Obviously the currency value that will be different, but at least proportionately whether it looks similar or not. Whether you think their bed charge and your bed charge are proportionately reasonable. Their medication charge and your medication charge are proportional. Whether if that is so, effectiveness is based on your randomized control trials. So whether you think that will be cost effective or not. But if they have not included something, if they have not looked at one of the outcomes, if they have not looked at one of the costs, then you have to add that on or add it to your analysis, and then you will have to arrive at whether it's going to be cost effective or not.